આવતી હતી?
હા ચાલશે સર, ચાલશે.
Sir, we are live now.
Okay. So, good evening, all esteemed faculties. Today we are going to discuss about one interesting and challenging case which we have encountered very recently regarding ACS scenario. Now, as we have already seen that in Euro PCR, it is not a didactic talk, but it is by and large a bilateral dialogue sort of presentation where the speaker gives you the condition and the underlying scenario, and he will involve all the panelists and the faculties to give their suggestion and their comments for the approach to treat this type of cases. So with that, let me start with the case of OCT guided PCI in non-estivation MI, presenting a case of a 52-year-old male who is presented with anginal pain, which is persisting since last 4 to 5 days, associated with profuse sweating, with the history of type 2 diabetes since 5 years, hypertension since 11 years, and dyslipidemia. At the time of admission, patient was having 130/80 of blood pressure, heart rate was 90, saturation was 98%, RBS was 206. ECG was showing changes which were pertaining to non-estivation MI, because this is the ECG. You can see that there are specific,
we are not seeing...
very, very specific. You are not able to see the ECG?
No, now we are able to see. Please go ahead.
Okay. So now the ECG is showing some very specific changes of multivessel disease, and we can easily appreciate the changes which are there in 1 AVL, V5, V6, as well as a very subtle elevation of AVR and V1 lead. You can also see horizontal depression with ST sagging in V2, V3, and V4. So this ECG itself gives you an idea about high-grade ischemia and hemodynamically significant lesion you can expect while doing while performing an angiographic picture. With this background, let me give you the idea about the laboratory testing, laboratory investigation. The cardiac marker was elevated. It was more than 200 times than the upper limit of normal. And it is suggestive of an acute bronchial injury because there was no specific elevated coronary syndrome. HbA1c was 7.3%. Patient's ABG was having PO2 of 83 and saturation of 98%. The blood investigation revealed hemoglobin of 13 gram, WBC 11,000, platelet count was normal, creatinine was normal 0.5, potassium was also normal, it was 4.2. So with this background, the echocardiography was being performed, which was showing a regional wall abnormality in the mid septum and the distal apical segment hypokinetics, hypokinesia was being seen. Valvular regurgitation was in form of mild in mitral region and tricuspid. Aortic valve was sclerosed. Ejection fraction was 35 to 40% with Elvis systolic dysfunction. Pulmonary arterial pressure was 40 millimeter of mercury. It was mild pH with grade 1 diastole dysfunction. IVC was collapsing, and there were no other major signs and symptoms. Now, with that, I would like to invite Dr. Anand Shukla sir to share.
And just allow me to share my
angiographic picture, the patient's angiographic picture. Yes, so I'll stop sharing here, and I will give rights to Dr. Anand Bhai.
Yeah, thank you. Can you see the angiogram?
Yes, sir, we can see that.
Everyone. So this is the angiogram that's been done from the right radial root with the tiger catheter, fibrin tiger catheter. Left main appears normal in RO caudal view. Ramus there is a large ramus arising, that is also in the at least mild to moderate disease. Circumflex run in the AV group, it also shows some disease. So here from ECG and echo, we predict some LAD significant lesion. So if you see PA cranial view, the osteoproximal LAD totally occluded and it not getting filled antegrately. Circumflex appear to be codominant because run in AV group left PLB given branch arising from the circumflex. So LA caudal view is very much informative. So if you see there is a ramus and just beside the ramus the osteoproximal LAD stenosis. Circumflex appears mild stenosis. Ramus having the here at least mild to moderate stenosis there. So in cranial view, also the LAD shows the osteoproximal total occlusion without any antegrade filling significant. So we are interested in the right coronary injection. We expect some filling of the left coronary from the right. This is the cranial view. It does shows the PLV arising from the circumflex. So appears to be the codominant circulation. PA caudal view, same finding. LA caudal and PA caudal are the good view for the LAD occlusion. This is the RC angiogram. Right coronary codominant, it give collateral to the LAD. If you see the one of the coronal branch, first coronal branch, it is immediately filling the proximal LAD. Good filling of the proximal LAD. In lateral view also, just proximal LAD start filling early. So now whole length of LAD we are filling through the right coronary. So overall scenario, what over to Jay, overall scenario, the patient is the ACS troponin positive, RWMN in LAD territory, R wave are not knocked down in the precordial lead, R wave are preserved, but cross chastity changes. So non-STEMI MI with totally osteoproximal occlusion of the LAD. So how we should, Jay will take forward the discussion with each our faculty and see what are the challenges we have faced during the opening of this vessel. Dr. Jai?
Yes, sir. So I hope everyone has seen the angiographic picture. So let me start with Dr. Sanjeev or Dr. Tarun Madan or Dr. Utsav Unadkar. How will you approach this type of case where you have first total LAD occlusion? There is a ramus involved, which is a sizable artery. You know that it is an acute coronary syndrome situation. So what is your approach for this type of patient and how would you treat your, treat such type of patient as far as the intervention is concerned?
Jay, you can stop your video. Video, so audio can be audible proper. Yes.
Okay.
Considering here,
Sanjay, please.
considering here the
Sanjay.
case of NSTEMI with troponin positive, there is no this one ST elevation, but there is a cross ST depression is there, and there's a very large LAD.
Sanjay, stop your video. We cannot appreciate your audio.
Okay, is it now audible?
Yeah, now audible.
Yes, yes.
Okay. So it's a large LAD, means it's an LMC which is trifurcating into LAD. Then LAD is osteoproximally occluded. There's a large ramus is there as well as LCX. So we need to preserve both the branches also. As an acute coronary syndrome situation, so ideal condition means in this condition I would go with possibly with a radial approach and with a 7 French slender sheath and 7 French EBU, and we can wire all the three vessels, ramus as well as LCX, and we go ahead with directly with an possibly of whisper or filter FCJ to open the LAD. looks like a fresh lesion, more of an acute on chronic, but looks like a more of a soft lesion. So usually can yield with just with a fielded FCJ, and we go ahead with a thrombosuction and then see the vessel, and then if imaging is available, then we do the imaging, and if it's a sizable vessel is there and no plaque or plaque is protruding into the left main, then we possibly may plan for left main to LAD after opening the LAD or after thrombosuction of the LAD.
All right. I think the plan is probably very well accepted. Now, is anyone wanted to say, or rather, will have some any other different modality or rather treatment? Dr. Tarun or Dr. Utsav?
Dr. Saurin.
Dr. Tarun? Tarun ने phone करना.
Mantavya, Tarun.
Dr. Mantavya? Yes, Dr. Mantavya, please go ahead.
Yes, sir. Dr. Sanjeev sir has explained very well that we should go ahead with the radial 7 fan sheath, 7 fan Cebu and wire all 3 branches because LMC is trifurcating, and we should open LED first with workhorse wire, and we should plan imaging if LED ostium is without plaque or uh, landing zone is there, then we should plan from LED ostium.
Tarun
Okay, Dr.
Utsav.
Tarun, you wanted to say something? Dr. Tarun?
No, I think let's see the case further. No comments as of now.
Dr. Utsav.
Dr. Utsav is there? Utsav Patel can also comment.
Kunadkar sir.
Kunadkar Sahib.
Bhavesh sir is there. Dr. Bhavesh bhai.
Dr. Bhavesh.
આપણે કોઈ કોમેન્ટ નથી અત્યારે તો તમે ચાલુ રાખો.
Okay. So what just I
Bhavesh bhai.
Jai, I conclude my analysis. So once we have reviewed the CD, it appears that there's a non-STEMI MI. Which non-STEMI MI, the culprit vessel is getting totally collateralized. So the lesion will be acute and chronic type, because to develop the good mature collateral, it requires the few weeks at least. So lesion might be the critical for the long time. Superadded some thrombus event has been occurred. That's why the good collateral from the RCA. So I predicted thrombus as well as the lesion. As Sanjeev has correctly mentioned that it is a slender sheath, but whether integrated wire has been parked in the proper channel or not. So that's why I planned the procedure in the dual mode. So dual radial, from radial I took the tiger catheter and femoral 7 fan guiding. So and as Sanjeev has also mentioned in plan out, wiring the ramus and the circumflex. We have also wired the ramus. Circumflex, because once we did the angio, there is some distal migration, proximal part of the LED become more clear. So it is not as plus as we are seeing the angio, but we have planned to wire ramus also. So by lateral approach, and Jai, you can start.
Now let us start with the live in box. Which are the steps we have taken into consideration?
Yeah. Please.
How we have planned the whole case. We have performed the angioplasty. So again, as you have already shown that it is totally occluded osteoproximal LED with circumflex artery, which is having a osteoproximal lesion, as well as ramus intermedius is having a long tubular lesion starting from the proximal part to the mid part, and RC is codominant and giving collateral to the left anterior descending artery. So the plan was to go ahead with the PTCA because imaging will give us the idea about the overall nature of the lesion, as well as we can, once the artery is getting opened up, we will be able to justify the landing zone, and then the actual optimization of PCA can be done with the help of imaging. So with that, let me go ahead with the findings. Let us not go ahead with the OCD finding right now, because we will give you the whole idea. Now this is the live in box that what we have recorded during the procedure. You can see that the SR has taken radial sheet. He has given a local anesthesia, and right radial access was being taken. The sheet was being introduced, and femoral root was also seen because we wanted to see the bilateral approach. The contralateral approach is also important to see. So femoral artery access was being taken, and now this is the injection, bilateral injection. What you can appreciate that this is the aerocranial view, where you can see that the LED is totally occluded, and in the aleocaudal view, you will be able to see the nipple of LED ostium. And this is the right coronary artery angiogram, which is showing the filling of LED and collateral circulation. Yeah, so this is how you can see that the LED is having a very well developed collateral. You can see that from this type of collateral that at least, what happened? Hello, you are able to see the screen or not?
No.
I'll reshare it. Something must have happened, and
Yeah. Slide is there.
okay. I'll make it in full screen.
Yes.
Okay, are you able to see the screen now?
Yeah. Yes.
So I'm just straight away going ahead
Next.
with that view.
Yeah.
Yeah, so this was the
Bilateral injection. Yes.
radial
So
artery access, femoral artery access.
yes.
You can see that bilateral injection is being given, and the right coronary artery angiographic picture is showing filling of LED, the remaining LED. You can see that the collaterals are very well developed. So I would like to here ask that, hello?
Yeah.
Hello, are you able to hear me?
Yes.
Yeah, but this is not working now.
So it
It is
not running.
no. It is there is some unstable network here.
Can I go with my PTCA presentation?
No. I'll share it with you in 1 minute only. So I'm just starting my own like hotspot, because here there is some unstable internet. Now are you able to see?
Yeah.
Yeah. So I
Next.
like shift to mobile network, and now
Next.
yeah, here the bilateral injection you can see.
The here still femoral. Yes.
Now you will be able to appreciate the ECG changes and the blood pressure
Yeah.
recording. You can see this
So,
patient is at hypotension.
Just stop here. Just I want to highlight. So this patient had borderline blood pressure and saturation was remain low. So that I underestimate that part, because I believe that only LED well collateralized. So that was patient was not decongested, and in lying down the saturation remain 88 to 90. So I should have taken the ABG and checked the lactate level and LV filling pressure before starting the procedure. That was not done in this case. Next, please.
Correct, correct. So the next point was that whatever maybe the condition, but at least you can see the sizable amount of interarterial collateral. That itself suggests is that the patient is having totally occluded LAD since last 4 weeks at least, because this type of collateral requires 4 weeks to develop. Otherwise, the collateral can start in a faint form in 48 hours after the occlusion. So we can assume that we are dealing with an acute and chronic sort of scenario with a thrombotic milieu inside the coronary artery. So the step was to cross the lesion. The lesion was being crossed with the workhorse wire run through, and then Versatile, sorry. And then the sir has done 2.5 by 20 millimeter of balloon was being taken. And here, soon after the balloon was being taken, it has produced a Malin seed effect at the ostium of the LAD. And after that, here you can see that the wire is being placed inside the ramus. LAD wire is there.
The problem I face because of watermelon seed effect, some thrombus migration. Some thrombus migration.
It's coming. So
Okay.
here you can see that the ECG is not having any major changes. But once he has done this ballooning, soon after that, patient has developed ECG changes. Patient was not feeling well. He had a chest pain. Patient was having hypotension. And here you can appreciate there is some slowing or slow flow which has been observed in the ramus. You can also appreciate the presence of balloon in the ostium of the LAD, which got Malin seed, and it has produced a seepage of balloon into the left main.
Jai, there is a lag in your commentary and the picture, because still it is showing the now we are seeing the balloon. Yeah.
Okay.
Okay. Now we are seeing the balloon. Yeah. Balloon inflation. Okay. Now we are seeing the balloon inflation. Yes. Okay. So what we'll do, because thrombus has been migrated in the ramus and the patient become unstable. Other faculty approach to dealt with such lesion. As Sanjeev has told to use the thromboster, but I didn't
Now,
use thromboster.
Yeah, look at this. Look at this angiographic picture. It has produced very slow flow. Here you can see that LAD is still totally occluded, and there is a significant slow flow in the ramus. This is very well visualized in the aleocaudal view. Thrombus got migrated in the ramus intermedius. In the epicranial view and aleocaudal, this was the pre-angiographic picture. And now in the post, you can see that the ECG changes. If you can just visualize the ECG changes.
Broad QRS.
Broad QRS complexes are being visualized. And at that time, even the hypotension was being there. So once we have stabilized with the help of inotropic support, we plan to do the OCT of that particular lesion just to identify the amount of plaque burden, the amount of fibrocalcific nature of the lesion, and the amount of lipidic low attenuated plaque inside the proximal part of the LAD.
So the ramus thrombus managed with the low pressure balloon 220 and a thrombosuction. And once the ramus get reopened and TB3 flow, patient started to get stabilized. So as Sanjeev has mentioned, thrombosuction, that part was missing. And second is the low pressure balloon.
Here the ECG changes are getting reverted. If you can just see the monitor, hemodynamic monitor, you can appreciate that the ECG changes are completely getting reverted. And this is the first OCT run. Now, for everyone to know that we are going from left main to distal part of the LAD. It is in the reverse way. What we do routinely, it is from distal to proximal, but this is proximal to distal. And here you can appreciate that there are multiple cracks in the lesion, low attenuated plaque, highly thrombotic, more lipidic, and there is a very patchy area of small calcified and fibrocalcific lesion was being observed on an OCT. So the idea was to go ahead with the stent. The stent was 2.75 by 38 millimeter sky point. That was being 38 millimeter, sorry. Sky point was being deployed, and it was post dilated with the help of NC balloon in a graded fashion. So the proximal part of the LAD was having a good area. 1.9 millimeter square was the area in pre-PCI, which was being further dilated with the help of post-stent NC balloon. And the proximal part of the LAD was being dilated with the help of 3 and 3.5 balloon. And distal part was being dilated with the help of 2.75 balloon. Now here you can see that the 3D bifurcation view. Now here you can see and appreciate the wire which is there in the circumflex artery and the wire which is running into the left main to LAD. And OCT, if you can appreciate that once the stent is started, it can lead to, I mean, it is showing a good MSA, and you can appreciate the well expanded stent in the osteoproximal region with a good TME flow. There will not be any edge dissection. There is no intramural hematoma. So this is how the whole procedure was being performed. Now, so I would like to request Dr. Anand Bhai to show the actual angiographic picture from his laptop.
Okay. So just I discussed. So problem with, can you see my screen?
Yeah, sir, I would like to share the screen again. Now to see, you are not able to see the screen. Your I need to stop sharing.
Stop sharing, Jay, stop sharing.
Yeah. Now you share your screen.
You can appreciate the. Can you see the angio? Hello.
Yes, sir. We are able to see
Yes,
that.
yes.
Okay. So the lesson I learned from this case, I should not have used the larger size balloon, because of I predicted the acute and chronic, but I didn't predicted the thrombus will behave such nicely. Once the watermelon seed effect of balloon has been done, the acute closure of ramus, you can appreciate the upper wire, the acute closure of ramus has been done. So immediately we give intracoronary adrenaline to maintain the did some low pressure balloon massage to the ramus and thrombosuction. Then we able to open up once the ramus has been opened, then the ECG stabilize. So that is the first part. Now once we also did the thrombosuction from the LED also, and after OCT, we came to know that ostial part of the LED near ramus is the area more than 5.5. So we are not going to touch that part. And this stent was deployed and optimized with the 3.5 proximal part. Distal part is 2.75 in the 3. And final result by this was the final result we achieved, and good flow in the ramus also. So patient did have hemodynamic. This is a OCT run before second last, and after that we came to know that still distal stent was under expanded. So we again redilated with the 3, and again we this was the final angiography result we achieved. So ostial of the LED, this part is not touched because area was more than 5.5, no thrombus, no only mild lesion. That's why. And the important thing, again, if in future such kind of lesion I have to tackle, I will go with the small balloon, not 2.5, 2 balloon. If I feel the watermelon seed effect, I'll just stop, do the thrombosuction, and again see the how the lesion behave. Here 2 time watermelon seed effect has lead to the ramus occlusion and the hemodynamic compromise. Now our other faculty give their comment how could have done better or what their opinion regarding the end result.
No, sir. Sir, give me 1 minute because you please stop sharing. We
Yeah.
are having still PPT left where we will be able to show them the actual OCT pictures.
Stop sharing.
PPT format. Yes. I hope you are able to see the screen now.
Yeah, but there are 2 devices you are connected. Some echo is there.
I know. Now is it clear?
Still you are echo.
Now it is clear because now I have removed the other device.
Still we hear your sound as echo. Yeah. Please, Jai, start.
So now here, if you can see that, now this is the OCT. I'm sorry. Yeah.
This is the pre.
So this is left screen. This is the pre. Yeah, this is the left main. Here you can see that it's very healthy left main. As you are coming closer, this is the bifurcation, and then the LED part will come. So this is the fibrotic nature of the, but the area is 6.1. So that is the reason Anand Bhai told that part was being left alone. It was already having a good MLA, and then comes this part, which is very narrow, tight. It is showing this is a classical low attenuated plaque, which is full of thrombus and the high lipidic plaque because you hardly see anything behind this. And this part, which is dotted, is having a little bit of calcium inside. And now you'll be able to appreciate that the tightest portion is having multiple fractures and multiple you will be able to appreciate that this part is having a multiple small micro dissections. There is a presence of a multiple dissection in the white thrombus and the red thrombus inside the lumen. And here you can see that this part is having a dissection. So that means the balloon has created dissection. It has produced a rupture of the plaque, and all the materials from the plaque, it has gone inside the lumen, and the lumen was completely occluded. And after that, this OCT will give you the picture of post PCI with the stent. Here you can appreciate the stent marking in a sunray appearance. You can see that it is well expanded, well opposed. There are a little bit of artifacts, dye artifacts are being seen, but overall, the whole stent is very well expanded, and we have done a proper optimization of that particular lesion. And this is the fly-through image. You can see that the wire is going to the circumflex, and the other part of stent is being visualized in a 3D view, which is well opposed without having any tissue prolapse or any edge dissection or intramural hematoma. And this was the post-procedure ECG. You can see that all the changes which were there in the lateral leads or the anterolateral leads and AVR and V1, they are completely reversed. You can see that the complete revascularization was being done with the help of OCT, and we could achieve a good MSA all throughout without any signs of edge dissection. The distal landing zone was being managed, and there was well appreciated LED areas, LED MSA area was being achieved, and the proximal lumen of LED was having a MSA of 7.8 millimeters square. So successfully we could achieve a good PCI LED with the help of imaging, and the post-procedural overall the procedure will remain uneventful, and the overall procedure stay was having a very good recovery. Patient was being discharged with the secondary prevention drugs in form of ticagrelor, and high intensity statin with ezetimibe. And patient has come in the follow-up, and patient is doing well clinically without having any major sign and symptoms of any angina or any dyspnea. The ejection fraction is going to be seen on the next follow-up, and all other lipid parameter and all other secondary prevention drugs are going to get titrated on the basis of the underlying reports. So thank you very much for the quiet listening, and over to whole faculties where they wanted to give comments or their suggestions regarding the lesion preparation, regarding the steps what we have used, and regarding the comments about how they would have approached case differently. Dr. Tarun? Dr. Tarun, Dr. Sanjeev?
हेलो
Yes, Dr. Tarun.
हाँ जी
Bolo sir, give your comments. By any chance, you would have something different?
Normally,
Any
routine practice,
different approach to treat this?
routinely, I usually prefer to go for after erosion was we wire the total occluded vessel. Ideally, usually without doing a pre-balloon dilatation, usually I proceed with just directly with the thrombustor. If I am not able to negotiate the thrombustor, then we pre-dilate the lesion, and then we take again the thrombustor to do the thrombosuction and then proceed for the further whole pre-dilatation. So, as sir has mentioned that even after total occlusion, also gentle balloon dilatation with a 2 mm balloon also, I would prefer that after wiring immediately go with just a thrombustor. If thrombustor is not able to negotiate, then go with a 2 mm balloon gentle dilatation, and then again thrombustor, and then proceed for further imaging also.
You are right. That could have.
Absolutely right.
agreed
Just have mute कराई दन. ભાવેશ સર ને મ્યુટ કરાવી દો.
મ્યુટ થઈ ગયું.
We would like to hear from you, Dr. Utsav Nadkat.
ઉત્સવ,
Both are almost like a innocent bystanders.
જય તારો અવાજ
Yes,
clear.
sir, I'm here, but your voice is echoing a lot.
Okay. Would you like to treat this condition differently? How will you approach this case?
I am not able to hear you, sir. Sorry, I joined late. I was busy in the OPD.
So Dr. Jay is
So,
asking, how would you approach this case differently?
okay. So, probably I think, image the both the vessels beforehand, if possible, and take a smaller balloon, as Anand sir said, because unnecessary dissection and slow flow and unnecessary complications are, sometimes there with, 1:1 sizing. So I think that is better. And otherwise, the, whatever complication that was managed very well, sir.
I think the point was well taken that yes, smaller size balloon.
Jay, your voice is echoing. So there is second device. You might be connected. Too much echo in your voice.
Jay bhai, you disconnect and reconnect.
Okay.
Sovereign,
Yes, Anand bhai, I think a very well managed case. Overall, nice result. And as you have pointed out, larger balloon to be avoided.
yes.
And imaging also is a great support for doing the case.
Yeah. So once I managed the ramus thrombus, then when I did the OPT, I directly went for the stenting rather than too much modification of the lesion, because already chaos has been initiated by the 2.5 balloon and some dissection was there. So I feel that I should directly stent the lesion and optimize the result as per the image guidance. So later part, but thrombus migration was the major complication, require intracoronary adrenaline, all these things.
Just wanted to ask, if there is an ostial part, there is a total occlusion, which method you prefer, to go from thrombosection from proximal to distal, or to deeply engage and then come from distal to proximal? Which is your proper method to go for thrombosection?
Theoretical, they are telling that you have to start proximally, but I always go distally and then start proximal, come to proximal, because I feel that if you start the proximally, the thrombus chances of thrombus migration will be the higher. But once you embedded the lesion distally and then start the thrombosuction, I have seen the less thrombus migration to adjacent vessel in my practice. But everybody can share their own experience.
No, I think my experience is that as soon as I entered into the thrombotic lesion, we usually do it, at the time of total occlusion, and then we go about and do a multiple.
Jay bhai, you open the negative suction valve in the proximal
Before.
part of occlusion, mid part of
Or
occlusion, distal
or
part
the
of
distal
occlusion.
part of occlusion.
Proximal part.
So as soon as you enter, you open it.
Correct.
So you are doing Dr. Sanjeev bhai, Dr. Jay bhai is saying proximal to distal.
In the proximal, just for the physics purpose, just if you start from the proximal, the chances that because of the suction effect, the thrombus will get more migrated towards the proximal, and very high chances to seepage into the circ lesion.
That is the opinion given by Dr. Anand bhai also.
Yes.
Yeah, that's what. Just we are discussing the part. What is the reason to go from distal to proximal and to avoid from proximal to distal?
Dr. Jay bhai, they are saying open the negative valve when you have crossed the lesion and reached the distal aspect.
Okay, we have done both the ways. I think I have not seen any major difference unless you know the subject well. I mean, unless you are very well versed with the hardware. I don't think that you are going to have any seepage of thrombus proximally. So one thing is very sure that yes, you need to continue the constant irrigation inside the coronary artery when you are starting, and you are also giving some small gentle push behind the stylus of this advanced export catheter, which will help in keeping the blood flow intact inside. So just by any sort of mechanism, I have not seen any sort of proximal seepage of thrombus just by doing a thrombus suction right from the proximal part.
We can take the house opinion. How I will go from distal to proximal. Tarun?
Distal to proximal, sir.
Distal to proximal.
Okay, majority wins.
Utsav? Okay. Any concluding remark from the Tarun Madan?
No, sir. No, sir. Nothing.
Okay.
So one thing is very sure that let us have a habit of doing imaging in such type of lesion, which is proximal, complex, involving left main, involving ostium of the disease. So it has to be mandatory in our group that we need to do imaging and then assess the lesion and then do the proper optimization of PCI with the help of imaging. So sometimes we use, especially for left main, always prefer to use IVUS. But whenever we are dealing with an ACS scenario or a thrombotic scenario, we always prefer to go ahead with the OCT. And now Abbott is having a console available in Ahmedabad, and they are ready to give us at our center. So whenever it's possible, we can always suggest to go ahead with the OCT guided PCI, which is especially when we are dealing with the post-stent ISR or any sort of stent failure you wanted to see or any sort of ACS scenario, then I'm sure that OCT is having a better visibility and better outcome as compared to IVUS.
Saurin and Dhruv might have joined the audience link.
Yeah, they've joined delegate link.
Delegate link. So we cannot take their opinion.
I think Jignesh.
You have to write it.
Yeah, sir. That is the I also asked them. પણ એવું લાગે છે કે ભૂલથી ડેલિગેટ લિંક જોઈન કરી છે.
They must have joined the delegate link.
એમને ક્લિક કરી એ બંનેનો ઓપિનિયન લઈ લેજો અગર within few minutes they able to rejoin.
Give me a
Just wanted
second.
to ask for the
Give
till
me
they
1
join.
second.
Just wanted to ask Jay sir and Anand sir, in young patients, when there is a very young patients up to 30-32 years, we see superadded just the thrombus. There is no typical lesion, no critical lesion. When do ACT, is there any difference? Whether for erosion we need not have to stent, and if there is a fissure or something, we have to stent the lesion like that. Just wanted, I don't know the this one concept.
જય પછી હું કહીશ જય.
So me and Dr. Tarun, we have discussed this just couple of weeks back, how to identify erosion and how to identify rupture or a plaque fissure or a fracture. So whenever you have an intact intima or endothelium is undisturbed or unruptured, that is where you will be able to see the erosion, and that is very well captured in OCT. So these are the lesions, they can be managed medically. But whenever there is a disruption of intima or endothelial is getting injured or ruptured, or there is a break in the endothelium, that is where you will be able to see the plaque rupture. You will be able to see the cavity which is getting filled with the blood, and you are having a big plaque rupture as a sac which is seen inside the OCT finding. So these are the lesions. They by and large requires intervention in form of stenting, and erosion can easily be managed medically. Anand bhai.
So usually in young patient, my first step is to avoid the metal if possible, scientifically. After thrombosuction, if I get the good, suppose imaging is there or not, there are two aspects. We are having the IVUS, but OCT not always on the hand. If OCT is there, then picture will be the clear. In IVUS, it difficult to identify. But angiographically, if good TME3 flow with residual minimum stenosis, I would do defer the stenting in such young scenario. I would keep on the maybe triple drug therapy, aspirin, clopidogrel, and anticoagulant for the long term. Tarun, your approach?
Same, sir.
So we try to avoid the metal in the young patient.
Young patient avoid the metal, and nowadays I think with the availability of DCBs, we can lace the endothelium with the drug and then avoid the metal. As we recently encountered a case in which there was a triple vessel disease and RCA was totally occluded. I had performed RCA intervention in the index event, and distal RCA was subjected to DCB. Then plan was to do LAD LCX and then check angiography of RCA revealed there was a restenosis of the DCB site. So we changed the plan and gave the patient for open bypass surgery. So metals, they come back with vengeance. And in a young patient, you may not get a high LDL, but if the extensivity of the disease is there, you have to understand that it's a malignant atherosclerosis and avoid the metal at multiple places. Though you may get a good result in a short term, but in a long term, endothelium behaves very badly.
Yes, agree. Bapu, I see the Bapu, Dhruv. And because the DCB one, we have to remove the thrombus as well, because drug will not going to absorb in presence of thrombus and the calcium. So in calcium, we have to crack the calcium. In thrombus, we have to aspirate as much as possible. So DCB drug can directly go into contact with the intima or vessel wall.
Right, sir?
All right then.
Yeah. Okay.
Thank you very much, RX Event.
Thank you.
Abbott,
Thank you so much.
with this
Thank you, sir.
opportunity
Good night.
and sharing your
Thank
valuable
you.
thoughts.
Thank you.
Thank you.
Good night. Good night.
Good night.
Good night.
Good night. Thank you again.